Again, I want to thank the organizers for having me and letting me speak in English. It's been very nice and very pleasant to be here. What we're going to talk about today really is one example of what the current and future capability of genomic testing is for treatment selection. And what I chose is a topic that I've been doing a lot of work on over the last 20 years, which is really how to predict effective treatment selection in early stage breast cancer. So these are the dilemmas when someone walks in with early stage ER positive breast cancer. The first question she always asks is, do I need chemotherapy? The next question, which I think is equally important, is, do I need endocrine therapy at all? We tend to believe that everybody needs endocrine therapy. Another question that we can ask, especially in a multidisciplinary clinic, is, can I get a complete pathologic response if you give me chemotherapy? Some really important questions I think that molecular testing is going to help us with are, do I need anthracyclines? We spent 30 years giving anthracyclines for early stage breast cancer. Maybe we don't need them. Do I need immunotherapy? We know immunotherapy works very well in early stage breast cancer and triple negative disease. Does it work in ER positive disease? And finally, I think one of the most important questions from a worldwide standpoint, because it's very, very expensive, is, do I need adjuvant CDK4/6 inhibitors? So I think many of you in this room are very familiar with the 21 gene assay, the Oncotype test. As you can see here, it's 16 genes with 5 control genes. You can take RNA from any sample anywhere on the globe and give a score, a recurrence score. It used to be under 18, it's now under 25. If you have a low recurrence score, generally you don't need chemotherapy. This is the TAILOR-RX study, which was completed many, many years ago. A very simple design of node-negative, ER-positive, HER2-negative disease that was T1C or T2. If you had a recurrence score of 10 or less, you got endocrine therapy. If you had a recurrence score of 26 to 100, you had endocrine and chemotherapy. If you had a recurrence score between the two, you were randomized to endocrine therapy with or without chemotherapy. And this shows the data. Actually, 15-year data will be presented soon. It was supposed to be presented at San Antonio. Joe Sperano instead decided to present something a little bit different. But you can see here, with a 12 years of follow-up, if your recurrence score is less than 10, you have a distant recurrence-free survival of 93%. If you had a 26 or above, your 15-year distant recurrence-free survival was about 85%. And this is an era before CDK4/6 inhibitors were developed. If you had a recurrence score between 11 and 25, you can see here your 12-year distant recurrence-free survival was 93% with no benefit to chemotherapy whatsoever. And because of this, generally in other trials, Oncotype DX, a 21 gene assay, is pretty much the standard of care in the United States. But what our group did about 15 years ago is we looked very carefully at what the genes were. And many of the genes we could actually measure with immunohistochemistry, Ki67, ER, PR, HER2. And if we're really good at immunohistochemistry, can we predict the recurrence score? And the answer to this is yes. We have about 10 years of data from our institution showing what are called the McGee equations. Anybody, this is available to anybody. You can do the Nottingham score, the ER, PR, HER2, tumor size, and Ki67 percentage, and you can actually predict the recurrence score. And we did this, we developed this on 855 samples that we had data on, tested them on a blinded set of 225 samples, 255 samples, and you can see here if the recurrence score was 20, actually, when you looked at our McGee equations 1, 2, and 3, it was the same. But I think the important thing is to look at the red circle. Anybody who had a recurrence score, an estimated McGee score of under 25, never had an oncotype over 25. And for this reason, we can use this as a pre-screen, and it can be used in areas of the world where we have immunohistochemistry, but not the availability of Oncotype DX. And so a lot of people, when they've seen this, have started to use this, and it works actually pretty well. This is how we use it in our group. If the estimated recurrence score is under 18, we don't send an oncotype in our group. If it's over 18, we generally do. But I think what this did was beg the question to us, which is, don't we need more information out of our genomic testing as opposed to chemo, no chemo? Can we get more out of the genomic tests we have for early stage breast cancer? And the answer is yes, there are other tests. In this case, the 70 gene assay, MammaPrint, does a lot more genes. There are 70 genes as opposed to 16, and almost none of these genes overlap with the oncotype score. Almost none of them are testable by immunohistochemistry. The only one that overlaps is the one called metadherin. It's a very interesting gene that we're not going to talk about today. But this is the MINDAC study, very similar. I think many people in this room are familiar with this, very similar to the oncotype study. About 7,600 women were enrolled in Europe. They had their clinical risk by a test called Adjuvant Online, which is no longer available. They had genomic risk by MammaPrint. If they both were low, about 40% of the time, they got no chemotherapy. If they both were high, they got chemotherapy and endocrine therapy. If, however, the clinical risk was high and the genomic risk was low, about 23% of the time, they actually were randomized to receive chemo, an endocrine therapy, or endocrine therapy alone. And these were a very high-risk group of patients. As you can see here, 60% were T2 or greater, all were intermediate or high grade, half were lymph node positive, and I want to point out the error on the bottom. 9.5% were triple positive. They were HER2 positive, and in general in breast cancer, we would give these patients trastuzumab, but 20% were low risk. And I think it really begs the question, if you have a T1C N0 tumor that's ER positive, HER2 positive, do they simply need endocrine therapy alone if they are MammaPrint low risk? And I think it's a question we've been asking in the United States for the last 10 years. However, in this test, if you were postmenopausal and you had a low-risk MammaPrint, regardless of whether you were node positive or not, your 10-year or your 9-year recurrence-free, distant metastasis-free survival was 90%, whether you had chemotherapy or not. If you were premenopausal, there was actually a 5% benefit, and most of us feel that benefit is due to ovarian suppression. We have a randomized clinical trial going on right now in the United States where women who have a high oncotype actually are being randomized to endocrine suppression with or without chemotherapy. And I suspect the ovarian suppression and aromatase inhibitor will be sufficient for these patients. However, can we go even further than this? And so MammaPrint actually not only gives you high risk and low risk, but low and what's called ultra low risk, high 1 and high 2. It can be divided into 4 different sections depending on the score. And one of the first things that people did when we learned about ultra low was look to see if ultra low can predict a group of people who do not need any therapy whatsoever. And so this is a group at UCSF. They took the patients who had a MammaPrint score of greater than 0.355 and applied that to the Stockholm study. This is 652 women who were postmenopausal, who in the 1970s and 80s were randomized to receive no therapy or therapy with tamoxifen, and they received either 2 years of tamoxifen or 5. 15% of all women had a MammaPrint that was ultra low risk. In this group, the patients who received no therapy had a 20-year breast cancer-specific survival of 94%, identifying a group who needs no therapy whatsoever. Now, this is only one study. What about other trials? Well, in the MINDAC group, the big group, actually went back and looked at their data, the group that did MINDACT. And in fact, 1,000 patients out of the 6,700 in MINDACT actually had a MammaPrint ultra low risk score. Those women, like the Stockholm trial, did the same. Whether they had endocrine therapy, endocrine and chemotherapy, endocrine therapy alone, their 8-year distant metastasis-free survival was over 95 to 97%. So we've identified a group of patients who need almost no therapy at all or minimum therapy, which is something I think that's very important in the breast cancer field, because a lot of women do not want to finish their endocrine therapy because of the side effects. And who are these people? Not who you'd expect. 26% had high clinical risk, a third were under 50, 20% had T2 disease or greater, and 20% had lymph node positive disease. We wouldn't expect that in this group. So this is important, and it has identified a group of people who need no therapy potentially at all. One question that always arises in tumor boards, multidisciplinary tumors, in discussion in breast cancer, is a woman comes in with a T3 lesion or a T2 N1 lesion, and we try to decide whether she'll respond to neoadjuvant chemotherapy. Should we put her through 4 to 6 months of chemotherapy, and can genomic testing help us? The answer is yes. Again, we have these group high 1, high 2, low, and ultra low. And so we actually went and looked very carefully at mammoprint high 2 versus high 1. Is this a simple arbitrary distinction? The answer is no. Actually, we can distinguish high 1 from high 2 through a variety of genomic tests. For example, when we do differential gene analysis, there are 1,400 genes that are different between mammoprint high 1 and high 2. They tend to be genes that upregulate things like DNA repair. So there's DNA repair deficiency in these set of patients. The PI3 kinase AKT-mTOR pathway is upregulated. The epithelial-mesenchymal transition pathway is downregulated. And cell cycle is upregulated. So these clearly are different patients. This is data actually from Lajos Puztai and his group at Yale. This is published about a year ago in Clinical Cancer Research. And I would focus on the middle and the right-hand panels. Patients who have mammoprint high 2 behave, they're ER positive, the tumors, but they behave as if they're triple negative. So the PCR rates of these patients are the same as if they were triple negative. And if they do not have a PCR, they behave just like a patient with triple negative disease. They have a recurrence rate, a distant relapse rate of about 30% at 5 years, just like triple negative disease. So it allows us to define who these people are. And so we went a little bit further. We have in the United States a very large real-world database. These are women who had a mammoprint in clinical practice. And we would go to them and we would do the 70-gene mammoprint and also a blueprint to get the intrinsic subtype, that is, are they luminal, estrogen-driven, HER2-driven, or neither, a basal type. And again, the 4 risk categories. We gathered all the clinical data and did a full transcriptome of all 22,000 genes and then follow them over time. And we have probably in this study right now, actually the first, it's done all over the United States. We have 2 sites in Europe right now, one in Greece and one in Israel. And I think we're still looking for sites, I'm not sure. But the bottom line is, as of a year ago, we had over 20,000 people. It's the largest database of its kind. And we have probably about 5,000 to 10,000 people right now that have at least 5 years of follow-up, allowing us now to ask questions about the transcriptome and what genes are associated and what therapies are associated with benefit. And so one of the first things we did with this was presented at San Antonio 2024, was actually look to see patients' response to neoadjuvant chemotherapy based on their mammoprint and blueprint scores. And what we found is that you're low-risk luminal A, have a very slow-growing ER-positive tumor, you don't get a very high PCR rate to chemo, 4.5%, which is what we expect. If, however, you have mammoprint high 2, you have a very highly proliferative tumor, and especially if it has the basal phenotype, you have a PCR rate of about 43%, which is typical and very similar to chemotherapy alone in triple-negative breast cancer. What was very interesting is that if you had mammoprint high 1, that is, you should get chemotherapy, these patients did not have a very high PCR rate, only 10%. So there clearly is something different between mammoprint high 1 and high 2. And we can use this. We use this right now off a core biopsy in our practices to determine who needs chemotherapy and who does not, and who will get a PCR and who won't to the neoadjuvant chemotherapy. But we've now taken it a little bit further, and I'll take the last 5 minutes to talk about where we are going, at least with mammoprint, and I think we're going this way with other genomic assays as well in early-stage breast cancer. The first one is, what about anthracycline sensitivity? Well, we know from the meta-analyses that anthracyclines give a benefit over CMF. We know that CMF chemotherapy was better than no chemotherapy. We knew that anthracycline-based chemotherapy is better than CMF. But the real question is anthracycline chemotherapy really better than taxane-based chemotherapy as adjuvant therapy in breast cancer? And it's a really open question. There was a trial called ABC, which was a combination of 3 studies using TC versus TAC, adding anthracyclines to TC times 6. That's docetaxel and Cytoxan, with or without anthracyclines. And in this, I know this is very difficult to see on the slide, but if you look at the bottom of the slide, there were numerically about 80 fewer recurrences in the trial in the anthracycline arm than the TC arm. But the problem is that there were excess deaths in the anthracycline arm, probably from heart failure and late leukemias, which offset any benefit that you had. So it really becomes important when you're giving anthracyclines to determine who really who gets the benefit from them. Who is going to benefit from this? So we don't have to expose them to toxicity. And in fact, we went back to our FLEX database, and one of the first things we found is that looking at neoadjuvant chemotherapy, if you were mammaprin high 1, you had no benefit to the addition of ACT over TC. If you were mammaprin high 2, though, you had a 32% PCR rate versus basically 0 from TC. Now, this is a very small amount of data. We went back and did it on a larger data set. In fact, we have an even larger data set than this that we presented at San Antonio this year. This is from ASCO a year and a half ago. But if you had mammaprin high 1, ER-positive breast cancer, you had no benefit to anthracyclines in terms of 3-year distant disease-free survival. However, if you're mammaprin high 2, you had an 11% benefit to the anthracycline. And this is actually also seen with oncotype as well, with the 21-gene assay. If you had a recurrence score of over 31, you had a 5% benefit to the anthracycline versus no benefit at recurrence scores under 31. So either mammaprin or more likely oncotype has actually described a biology where there is benefit to anthracyclines. And this is now part of the NCCN guidelines. We have a large clinical trial going on right now of looking at the ABC trials where we're applying the mammaprin assay to them. Hopefully we'll be presenting this data at a medical meeting within the next year. But what about immunotherapy sensitivity? We know in triple-negative breast cancer, immunotherapy and chemo is the standard of care. What about ER-positive disease? Well, the Keynote 756 trial, which was presented at ESMO over a year ago, more than a year and a half ago, took women with locally advanced breast cancer that was ER-positive and gave them paclitaxel, epirubicin or doxorubicin, Cytoxan, with or without pembrolizumab, with or without an immune checkpoint inhibitor. And in this trial, about, I would say, 10% of the patients had an estrogen receptor less than 10%. And in those patients, you can see here, with a CPS score greater than 1, there was a benefit, 56.6% PCR rate to these patients. We all knew this. These patients are more basal-like. It's not a surprise. However, the majority of patients either had a CPS score less than 1 or an estrogen receptor greater than 10. And the benefit was far more modest in those patients. So can we define a biomarker that'll help us figure out who will get benefit from immunotherapy? In fact, we have a trial called I-SPY, which is a variety of neoadjuvant therapies that are being tested. And in the I-SPY trial, every patient had a mammaprint. If you're a mammaprin high 1, the PCR rate of the patients to immunotherapy, you can see 3 different immunotherapies here, the PCR rate was about 10 to 15%. However, if they were mammaprin high 2, the PCR rate was 60 to 65%, a difference of 40% with the addition of immunotherapy. So we may, with mammaprin high 2, and again, there's a whole, I don't have time to talk about it, but there's a whole molecular biology of why this is. But the bottom line is, in the US, we have a clinical trial right now called SWOG 2206, where patients who have mammaprin high 2 and locally advanced breast cancer that's estrogen receptor positive are randomized to standard of care chemotherapy, ACT, with or without durvalumab. And we believe, we've already accrued probably half of these patients already, we believe the PCR rate is going to be higher in the experimental arm with durvalumab. We hope that. It may not be. That's why we do the experiment. One last issue is we think at some point molecular tests will allow us to decide who gets CDK4/6 inhibitors and who doesn't in the adjuvant setting, a very big question. And so we've had this 11 gene signature that was found in cell lines. So there are cell lines that are resistant to palbociclib. They have 3 different profiles. Profile H, which means it's sensitive. Profile L is intermediate. Profile A is resistant. We applied this to our Flex database, and what we found is the vast majority of the resistant profile was found in the Mammaprin High-2. So we believe that Mammaprin High-2 not only tells you who will benefit from immunotherapy, but potentially who will not benefit from CDK4/6 inhibitors. Now, this has to be replicated on large databases. We're currently working with the PALLAS database, which is adjuvant palbociclib, to see if this signature really does predict for CDK4/6 inhibitor benefit. So I'll just finish with this. I think the future of genomic testing, and again, there's so much to talk about. There's a multidisciplinary audience with many different people. I am a breast cancer physician, and I think the future of genomic assays for ER-positive early-stage breast cancer is going to be one assay. It could be Mammaprin, it could be something else, but one assay off the core biopsy that will tell us everything. Chemo, no chemo, need for endocrine therapy, length of endocrine therapy, the possible response to anthracyclines, possible response to immunotherapy, and possible benefit to adjuvant CDK4/6 inhibitors. And again, thank you very much for listening to me in English. I know this, it's hard for me to do it in Czech, but thank you very much. Thank you.
Thank you, Professor Brufsky, for your outstanding, comprehensive lecture. But I think it's possible to open discussion. Pane profesore, ale každá přednáška je o něčem trochu jiném, tak my ještě tak bychom otevřeli teď na chvilku diskuzi, pokud někdo máte otázku. Professor Brufsky, is Mammaprin suitable as well for premenopausal women?
Yes. The answer is yes. I think it works for both pre- and postmenopausal women. We have a whole group of patients in our Flex database, probably about 5,000 that are premenopausal. And it's very interesting to note that we've looked at the Mammaprin scores, we've looked at the whole transcriptome in pre- and postmenopausal women, and it's pretty much the same, believe it or not. Very few differences between the two. Yes.
Thank you so much. Máte někdo otázku? Ano, tamhle Zuzka. Zuzana.
Thank you. I have 2 questions. First one, if you use both Oncotype and Mammaprin, and if you have any recommendation which one to use, especially for patients with clinically low tumors, typically with high Ki67 probably. And second question, if you have any guidelines for patient or in indication of Mammaprin on another test in patient preoperatively. I mean, for example, because we are afraid of N+ disease, especially in grade 3 tumors. So if you have any guidelines, for example, for biopsy to avoid misindication of genomic tests. Thank you.
So I think the first question is, I think Oncotype does well, but it can be replicated by immunohistochemistry. That's the first thing. And I think that both work very well for their primary purpose, which is to determine who needs chemo and who doesn't. And I think I could go for either one, and I've used both in my practice. I even use EndoPredict, which I know is available in Europe. I'm probably one of the only people in the United States who still uses EndoPredict, but I use all 3 because they all do what they're supposed to do. I think what Mammaprin gets us is all of this additional data that we wouldn't have had with Oncotype. Oncotype doesn't have this actually right now. And so I think there are a lot of patients who, if I want to know all of the other things, I'm going to use Mammaprin instead of Oncotype. In terms of when to test, I think if I understand the question correctly, it's when to do it and where to do it. If it's multifocal disease, I tend to take the tumor that has the worst prognosis, the one that maybe has the lowest ER, the one potentially that has the highest grade, the highest Ki67. That's the tumor I tend to test, but I always do it preoperatively. These tests have to be done preoperatively. because a genomic profile changes with neoadjuvant therapy and it changes with neoadjuvant hormonal therapy. So we have to do it before. I think if I understand the question correctly. I don't know if I answered it.
Tady prosím vepředu v druhé řadě.
Yes, considering the relatively high cost of both MammaPrint and Oncotype, for the prediction of the neoadjuvant therapy efficiency, do you think there are some other ways for other molecular tests, such as circulating DNA, free DNA, or circulating tumor DNA? Some people were looking at fragmentation of free DNA.
Absolutely.
You see any use of that?
Yes, and so the first question is, we've actually published a paper that the McGee score will do a very good job of predicting PCR. So you can use that if you have good immunohistochemistry. I think it's going to be a completely separate question. It's going to likely be replaced with circulating tumor DNA. I think that there's data that was presented both at ASCO and San Antonio that suggests that if you have a negative circulating tumor DNA at the end of neoadjuvant therapy, your prognosis is predicted better than it would if you had a PCR. And so that is where we're going. The data is still very small. The trials are not large. We need to accumulate a little bit more data, which is being done in large clinical trials. A big clinical trial called NSABP B64 that's sponsored by Exact that uses an MRD test that basically is going, we believe, is going to show that the same thing, that if you have clearance of your ctDNA at the end of neoadjuvant therapy for breast cancer, we don't care what the residual disease looks like. It's likely going to predict for an excellent 5-year distant disease-free survival. And I think that's probably going to be the best thing at some point in time. But right now, we're still in this intermediate kind of area where we don't have that yet with enough data. Yes, great question.